Good afternoon, everyone. The time is now 12:30, so we will get things started. Welcome, everyone, and thank you so much for joining our geriatric knowledge mobilization rounds this afternoon. My name is Jenny Seaman, and I'm the director of the Regional Geriatric Program Central, and I am very pleased to moderate today's session. Our original moderator, Dr. Mihaela Nicula, had an unforeseen circumstance arise, so I will do my very best to harness her wonderfully positive energy. I wish to begin today with a land acknowledgement. I'm currently located on the traditional territories of the Mississaugas, Haudenosaunee, and Anishinaabe within the lands protected by the Dish with One Spoon Wampum Agreement. We acknowledge that we have guests joining us from across the province today, so I encourage everyone who is here with us to reflect on the territories upon which you live, work, and play as an act of reconciliation. Our webinar today focuses on nutrition care for people who are living with dementia during and after hospitalization. This is wonderfully fitting, given that it's a lunch and learn, so hopefully everyone's able to take an opportunity to nourish yourselves as you join us and learn together today. This is a joint offering representing a partnership between the Regional Geriatric Program Central and the Geris Center for Aging Research. The excitement and enthusiasm for this topic has just been wonderful, and we are pleased to have had over 85 people register for today's session. From a housekeeping perspective, we are meeting today via a Zoom webinar. As our guests, your cameras and microphones have been muted, but we do invite you to participate via the Q&A and chat functions that are visible in the ribbon at the bottom of your Zoom screen. We will take a few moments to answer questions at the end of today's session. Following the webinar, a survey link will appear requesting your feedback, and we really ask you to take 2 or 3 minutes to share your thoughts on today's session. Your feedback is invaluable as we build our future presentations. With that, I'm very pleased and thrilled to introduce today's speaker, Dr. Heather Keller. Dr. Keller is a professor and Schlegel Research Chair in Nutrition and Aging at the University of Waterloo and the Schlegel UW Research Institute for Aging. She is an internationally recognized expert in geriatric nutrition, assessment, and treatment. She has led several national research and knowledge translation projects, including the landmark Nutrition Care in Canadian Hospitals, More to Eat, and Making the Most of Meal Times in Long-Term Care Studies. With that, I am so pleased to hand it over to Dr. Keller.
Thanks very much, Jenny. So just going to get my slides up as well, and hopefully we'll be ready to roll. So can you see my slides properly?
We are seeing the presenter view, Dr. Keller.
Oh, okay. Swap display. Is that better?
Unfortunately, they still are the presenter view.
Oh my goodness. Okay, let me stop share then for a moment. Okay. Right, so now we'll switch. Is that okay now?
I'm sorry, Dr. Keller, it still is the presenter view. Do let us know if we can share the slides for you. We're happy to do that.
Maybe you should share the slides. I'm having that problem with my Microsoft as well again, so I'll just stop that. I'll just let you know, change slide by. So I'll stop sharing.
Are you sharing, Jen? I am sharing. Hit Control L. Nothing?
Sorry about this, folks. Technology always fails you when you need it most. But we'll get it going in a moment.
Maybe just to make sure that we have adequate time for your wonderful content, Dr. Keller,
Sure.
we'll just proceed with this view. Thank you.
Do you want me to share my slides again?
Oh no, if you could just, if you wish to begin your presentation, we'll just
Okay.
go ahead. Thank you.
I can't see any slides.
Oh, goodness. They are visible from our perspective.
Okay,
Perhaps
I'll put my own up and then we'll go from there. How's
let's
that?
do that.
All right, so maybe just slip first the disclosure slide. That would be great. Oh, there we are. Now I see it. Okay, terrific. All right, next slide, please. All right, so today we're going to be talking about the patients with dementia specifically in the hospital setting and talk specifically around malnutrition, eating and drinking challenges for these hospital patients. There's actually very little research about people living with dementia in hospitals, so I've had to draw on some other evidence as well to support this discussion today. Then we'll follow up with some best practices for nutrition care and finally rounding out a presentation with practical tips. Next slide, please. So in Canada, this is data from CIHI in 2022 to 23. That's the most recent stats we have. You can see the top 5 reasons for a hospital stay. And pneumonia is the 5th most common. It's actually the principal cause of hospitalization for 55% of people who live with dementia, actually. So this is an important statistic to see that there's quite a few people that are coming into hospital with this condition, and many of them might have dementia as well. Next slide, please. We know that we've had an increase in hospital admissions from 2021 to 2022. It's not decreased in number by any means. However, the average length of stay of a patient in hospital in Canada is the same as it was in 2021 in 2022-23. As well, the alternative level of care beds are about 6.2% of those admissions. Next slide. We know as well that about a third of the hospitalized older adults, so people at 65 years in age or older, are also at risk for frailty. So we're going to see a frail population coming into hospital, staying on average a little bit longer perhaps, and maybe ending up as an ALC admission. Next slide, please. What we do know specifically about dementia, again, these are Canadian statistics, that persons with dementia will come into ER. They will stay two and a half hours or so longer than an admission that does not have dementia. About 2/3 increase or 65% increase rate of admission, up to 2 times longer stay in hospital. And they're going to experience more harms as well in hospital, like UTIs, dehydration, pneumonia, and delirium. Next slide. This research is from outside of Canada, but demonstrates some of the reasons why people come to hospital with dementia and what we're seeing in terms of their stay. So they're more likely to have emergent reasons for coming to admission. They're not having elective surgeries, more likely to be admitted with syncope and collapse, bronchopneumonia or low respiratory infections, UTI, dehydration, anorexia, hip fracture, and septicemia. Aspiration pneumonia and recurrent infections are another common outcome that's seen in a hospital with these folks. Unfortunately, many of them will have dysphagia that might not have actually been diagnosed. Increased disorientation and increased confusion as well. Increased responsive behaviors. We'll talk a bit more about that when it comes to eating assistance, and prone to overstimulation in the eating environment and dining environment, or basically in the room where they're eating their food. Next slide, please. So what do caregivers actually say about their experience of their loved one being in a hospital? This is actually studies from or research from Halifax, Dr. Moody and colleagues at Dalhousie University, just recently published. I'll let you read those quotes for a moment. So you'll note on the right-hand side, the one quote there, this is actually a quote from the paper, not quotes from participants. But the hospital setting seems to have practices in place that are set to default to provide efficient care in a hospital setting, but that often is not appropriate for a person with dementia. And that's what we're going to focus in on today. Next slide, please. So I'm basing much of the discussion today on the Canadian Malnutrition Task Force. You may not be aware of this group in Canada. We've been in existence for 13 years or so, 14 years, I guess now. And our mandate is to promote adequate nutrition care in all healthcare sectors. But we started our work by looking at the hospital sector. And I'll be showing you some of the research we've done in that sector, including the problems that we identify, but also some solutions with the More to Eat studies. The tips and tools that we've got will be based on that website. I actually have some links later on when we get to that section. Next slide, please. So first off, what is malnutrition? So malnutrition results when there's an imbalance between nutrient intake and nutrient requirements. Malnutrition may occur if there is inadequate intake, impaired nutrient absorption, or an increased energy expenditure. So it has many causes, right? However, you're not malnourished unless it's sustained imbalance that leads to a functional change in the body. So you might not eat enough vitamin C this week, but you don't see scurvy, right? It's a sustained long-term imbalance that's going to result in those changes functioning in the body. This can be seen as muscle weakness, muscle loss, immune function, problems, capacity for recovery, cognition, etc. You know it's malnutrition when it responds to refeeding. So sometimes malnutrition can look like sarcopenia or cachexia, and obviously those will impact the nutritional status of an individual, but they do not respond as readily to refeeding. We do know that inflammation, so when someone does have increased CRP, for example, or has had an assault to the body, that inflammation is going to make it harder to respond to refeeding as well. So this is how we have to address that both medically as well as nutritionally. Next slide, please. So there's been quite a bit of work, as I said, done in Canada over the last 13 years looking at nutrition risk and malnutrition in the hospital setting. Some of these stats here are actually about nutrition risk in the community. So you may not be aware that 1 in 3 seniors, based on the Canadian Longitudinal Study of Aging, have nutrition risk, and they're coming into hospital. Anywhere from 1 to 2, 1 in 2 to 1 in 4 people coming into hospital will be malnourished. And they tend to stay longer in hospital. And if they do get discharged, they're often readmitted to hospital again. So again, we want to fix the malnutrition when we do see it in the hospital setting. And I'm making this stretch to say that many people with dementia, we might come in well nourished, but perhaps some of the practices we put into place in hospital might actually lead to poor food intake and a longer length of stay and poor recovery, potentially even malnutrition. Next slide, please. So from the Canadian Nutrition Care and Canadian Hospital Study, we have several key statistics. Again, they're not specific to persons with dementia. However, I think they say something about the care process we need to put in place for people, all patients, including people with dementia. So as I said, up to 1 in 2 patients come into hospital malnourished. They're not identified typically by physicians and nurses at admission. So we need to put into place a screening process, an efficient and effective screening process that can identify people quickly to get the dietitian in place. We know that malnourished patients will stay longer in hospital, and the longer they stay, the more likely they are to decline in nutrition as well. When a person doesn't eat 50% of the tray, that's about 30% in this study, about a third of people. They also will not stay, they will stay longer in hospital. So a third of people not eating 50% of their tray, and they're then going to stay in hospital longer. They don't like the food, perhaps. Maybe they're not receiving the food in a timely way, etc. Those dissatisfied with food quality also stay longer in hospital. And there's many organizational barriers to food intake. And we'll show you those in the next slide. And I think many of these would occur for persons living with dementia in hospital as well. For example, they may need help to eat, and they don't get that. We found 42% in our sample had that challenge. They might be in a poor position for eating, 27% in the study that we did. Maybe they're interrupted by staff at the meal, 42%, etc. Even reaching the meal, about 1 in 5 people couldn't reach their meal because of the way they positioned in the hospital. So these are some of the barriers we saw again for all adults that were part of our nutrition care and Canadian hospital study. However, expect they're even more common for people living with dementia. Next slide, please. So what are some of the best practices to support nutrition in patients with dementia and patients overall, quite frankly, in hospital? Next slide. So we need to implement nutrition screening and triage for dietitian assessment. We've actually conducted a series of studies around this, identifying what is best practice in hospital to find those patients that might have nutrition concerns, might be malnourished, and also when they're not eating well in hospital, find them so we can quickly intervene and they can recover. By putting screening in place, you're going to have earlier treatment, as well as having the dietitian involved can lead to follow-up that goes into the community setting as well, which is really needed for malnourished patients. They don't stay in hospital long enough to recover fully their nutritional status. As well, we need to implement improved standardized care procedures to promote food intake. This, I think, is a big problem for persons with dementia. Again, they might be coming in well nourished, but if the standard care that we put in place makes it hard for them to eat, or they're confused, they might get delirium, etc., this can extend their length of stay, but also then lead to potentially poor food intake and malnutrition. So we need to attend to the barriers to poor food intake in the hospital setting. We need to monitor food intake on a routine basis to understand when further treatment is needed. We need to have food available on the unit. This might be something you've never tried before, but having that food available when people are outside of meals and they're hungry, this is a good opportunity to provide that care for people. Having volunteers involved in meal support is important if you can arrange that. And we have some guidance on that, some tips later on. And also trying to include the family as much as possible in the mealtime process. Allow them to bring in food, for example, and store it in the refrigerator that's on the unit. Provide that food at mealtime if the person doesn't like the food that's available to them. And then finally, coordinate with primary care at discharge as well as home care to ensure that there's a continuation of nutrition care services as people move back to the community. We need to educate family and patient on their needs around nutrition to keep them out of hospital again. Arrange home care supports. If it's appropriate, use oral nutrition supplements and prescribe that so they're included in their package when they leave the hospital and then are started when they get back home. And then finally, have a referral to a home care dietitian or primary care dietitian to follow through and follow up with that patient. Next slide, please. So there's a few studies that I want to cite around specifically dementia care in the hospital. And so this was one around preventing delirium. It was based on 22 randomized control trials. And they found that multi-component interventions, which included nutrition and hydration, could reduce the incidence of delirium in patients in hospital, as you can see. Next slide, please. Specific to persons with dementia, this qualitative review looked at 20 studies and what they suggested basically to support these patients in hospital. So knowing the person, that idea of person-centered care and their preferences and involving families to support them during meal times is very important. Enriching the food, having texture modified food if the person requires it. Again, this is where having the dietitian involved in these patients is important. Encourage eating, so preserve the dignity of the person, maintain a human connection, maintain visual contact and verbal encouragement, and ensure that you have oral hygiene to prevent aspiration post the meal. And then finally, they talked about the idea of environmental modifications to, again, decrease that concern about not understanding the environment, maybe leading to responsive behaviors for the person with dementia. So use routines and routines that work for the person as well with dementia, not just the routines of the hospital. Use reminiscence to help bring them back to the moment and talk about what's going on. Involve family in their care. Have a quieter environment and focus on the pleasure and enjoyment of meals. So you can see some of these things would address those quotes that we saw in the Moody study about not being involved, not being listened to, and people in the care of these people might not having the experience with persons with dementia. So doing that person-centered care again. Next slide, please. This is an interesting study where they had a variety of strategies to promote people and decrease delirium. And I'm just showing you here the EAT goal. So they had walking and engaging people as well in the hospital. You can see the eating strategies are varied. Things like having snacks available on the unit, encouraging family involvement meal times, even having a group morning tea in a common room, having mealtime assistance again with volunteers, meal delivery being prioritized, nursing prompts to encourage meals, and the nursing workflow worked around the meal time so that there weren't breaks and all the staff that were available on the neighborhood or the unit so that assistance could be provided. When this Eat, Walk, Engage strategy was put into place, there were fewer complications with patients, they had 1 day shorter length of stay, and a significantly decreased incidence of delirium again. So again, an important way of thinking about this more holistic view of ensuring that meals are consumed, people are getting enough to eat, they're getting the right types of food, and being engaged with staff to ensure that they're getting encouragement that they need is really important. Next slide. So that sounds rather lofty, doesn't it? I'm sure those studies that talk about multi-component interventions to decrease delirium and promote food intake in older adults with dementia in long-term care, or in hospital. Let's go to now some practical tips and tools. And these are taken again from the Canadian Malnutrition Task Force. And hopefully they'll lead you to thinking about some ways you can change your practice. Next slide, please. So this is actually, again, from Moody, some recommendations from their discussion in their paper. So have a way of sharing the information about the person for hospital staff. This could be something on the bedside that supports all the staff to recognize the person needs their hearing aid and glasses on when you're communicating with them so they can hear properly, for example. You could also make sure that you put detailed notes in the nursing cardex or the electronic health record specific to around the person-centered care needs of the individual with dementia. Have staff, all staff, dietary staff, staff that might be coming into the room to clean, etc., as well as nursing staff, have them trained on dementia and skills for preventing and managing responsive behaviors. Everybody that could have contact with a patient should be trained in dementia care and the skills that are needed. Reduce the stigma as well of all staff towards dementia. And so this is part of that training can support that decrease in stigma. Consider how your physical environment can be enhanced. Perhaps symbols for navigation, for example, having a toilet symbol on the toilet door rather than just the name or even nothing there on the door name on the door. Lighting, making sure the lighting is appropriate, but also in the evening, the lighting's turned off in the hall or in the room so that people can sleep properly. Removing clutter, especially in the room so that they don't fall, and preferably in other areas too, so that can support the feeling that it's a place they can navigate better. Think about the processes that you put in place and what needs to be modified to support people with dementia. We often will see a person not conforming to our routines, our way of doing things, and the response is often antipsychotics, unfortunately, for that individual, and that is not the right response. So again, we're training on dementia how to respond to those behaviors or challenges of providing care to a person when they don't seem to understand the environment. That's where training will be very important. As well, understand the unique needs of the individual and try to meet these needs. That's going to lead to that person-centered care. And finally, adapt those routines that you've got to try to make sure that processes are adaptable and flexible enough to support individuals. Finally, provide activities that address boredom. Moody actually talks about the need for more recreation staff in hospital, in medical wards especially, and things like a walking program could be done, but recreational activities are very important to keep people engaged and to stop some of those potential responsive behaviors again that might happen in the hospital setting. Next slide, please. So now we'll switch to some of the tools that the Canadian Malnutrition Task Force has created. So as I said at the beginning, nutrition risk screening would be an important step. We do it with a 2-question screening tool that is validated, and it's available at this website. There's also a short video on nutrition screening. So if a person identifies or their caregiver, their family caregiver says yes to the 2 questions that are indicated there, that indicates a person's at nutrition risk, and they should be referred to the dietitian for the next step in terms of determining if they truly have malnutrition and providing that care. As indicated as well, monitoring food intake is very important. It's an indication that someone's not doing well in hospital and will lead to a longer length of stay, longer recovery, perhaps even more malnutrition. And so there is a food intake monitoring in hospital video there that might be of use to you. Next slide, please. We have a variety of tray liners and pamphlets that are available to put in on your patient menus, or sorry, on their trays as they're coming to them. One that talks about a pamphlet on the left-hand side while you're in hospital, things to be looking out for as family and patient, and to be recognizing the importance of food and nutrition. Then the middle is a tray liner, and then on the right-hand side is a pamphlet for when they're leaving hospital. Again, some of the key principles we talked about here today about that follow through into the community, using oral nutrition supplements as needed, getting family support around meals coming into the home or food coming into the home, that sort of thing. So keeping it top of mind, the importance of accessing food, getting the nutrition that people need. Next slide, please. We also have a web page that actually talks about several tools to involve volunteers. So if you'd like to think about getting volunteers involved in your medical or surgical wards, these would be some great resources for you, and the link is there as well. Next slide. And then finally, thinking about auditing your practice. The tool I've got here is actually to be used by a staff member or volunteer asking a person about any of the barriers they might have had at mealtime. So this can help you identify as a team on your unit where you need to make improvements. Maybe there's too many interruptions happening for an individual, or maybe they're not getting their meal set up properly by the person who drops the tray off, and that's led to a barrier to food intake. So by auditing your practice, you can then think about how you can put into place some preventative actions and quality improvements. So our final slide, please. So to summarize, you're going to see more and more patients in hospital who have cognitive impairment. That seems to be what we're already seeing, but it's going to increase as we see more and more people living with dementia and aging in our communities. Malnutrition and poor food and fluid intake in hospital are very common. One in two to 1 in 4, depending on the type of population and the type of unit that people are going into. Proactive treatment is needed, so screening needs to be put in place to identify these people quickly, as well as thinking about the standardized care practices we have in hospital to make sure food gets to patients. When people eat the food, they will then recover, right, and leave the hospital sooner. And then finally, the Canadian Malnutrition Task Force, there's lots and lots of tools on our website. I've just shown you a few of them today. If you're a dietitian that's online today, there's lots of resources to support you as a champion to start some of these change processes on your unit. Or as a nurse, if you're interested in getting an initiative going, let us know and we can support you in starting that. Please let us know by our website. There's actually a link there to an email to us, or you can email me directly as well. So with that, I thank you very much, and we can have some conversation about this work.
Thank you so much, Dr. Keller, for your fantastic presentation. You distilled so much literature into some practical takeaways that I think we can all implement into our practice. So thank you so much for that.
Most welcome.
I
A
will
little
just
fast, I agree, but with our
Just wonderful, though. Thank you, Dr. Keller. I will make a final call that if anyone has a question that they would like to pop into the chat, we just have a couple of minutes left. Um, but perhaps I will offer a reflection rather than a question, Dr. Keller, just to say that we hear a lot and we speak a lot about senior-friendly care. And I think that nutrition fits so well with that idea that um, it's excellent care for everyone, not only our patients who are living with dementia, but for all older adult patients as well. If you have any reflections on that. Oh, sorry, Dr. Keller, I can't hear your audio actually.
Can you hear me now?
Yes, I can. Thank you.
Okay, not sure what happened there. Absolutely. The Senior Friendly Initiative is totally in line with the recommendations that the literature is talking about here around nutrition care and what we're doing as well with the CMTF, the Canadian Malnutrition Task Force. So all of the things we talked about are very much in line with that. And this, as you say, Jenny, support all patients, not just patients with dementia, but better care for everyone, right? And so we can lead to shorter length of stay, we hope. Yeah.
Thank you so much. I see one question,
Great.
not a question rather, but a reflection again in the Q&A.
Sure.
Gail says this was a wonderful talk, succinct and full of practical strategies. Thank you so much.
You're most welcome.
Well,
Check
I
out that
think
website. You'll find more things there.
Thank you so much, Dr. Keller. I think that's a wonderfully positive note on which we can end today's webinar. So we wish to thank you so much again, Dr. Keller, for joining us. Thank you very much to our participants. Please do take a few moments to complete the survey that will be available to you at the end of today's session. Take care, everyone.
Thank you.